Good evening and welcome to our Abbott webinar on mastering TAVI, techniques to optimize procedural success. My name is Anita Asgar and I have the pleasure to be joined by Dr. Bassem Shahab and Dr. Santiago Garcia. And we're going to be speaking to you tonight about mastering TAVI with the Navitor system. This is our agenda. So we're going to start by talking a little bit about the Navitor Vision, some techniques to optimize procedural outcomes, and we have the pleasure of reviewing a live case with Dr. Shahab, Dr. Santiago, and myself, and then we're going to have the ability to ask questions. So you are able to put questions in the chat. If you have any questions, please feel free to put them in there, and we will do our best to answer them. So just a little bit of information on conflicts of interest. And so I'm going to start this evening talking to you about the Navitor Vision transcatheter heart valve and the FlexNav delivery system. So as most of you are hopefully aware, this is the Navitor TAVI system with the Navitor Vision valve. It is an intra-annular self-expanding valve. It has a nitinol stent frame with both an inner and outer sealing cuff, and the leaflets are bovine pericardium. As you can see from this image, we have large cell geometry, and you can see in the little red circle the Vision radio opaque marker. In terms of the FlexNav delivery system, important to remember this is a low-profile, sheathless, and very flexible delivery system. And in fact, it's 14 French equivalent for both the 23 and the 25 millimeter valve, and it's a 15 French equivalent for the larger sizes. And the nice thing about this system is it can tackle the smallest vessel sizes that we have with any device on the market, with a minimal vessel size of 5 millimeters for the 14 French and 5.5 for the larger. There's a stability layer to assist placement accuracy and stability of the catheter, and it's hydrophilic coated. There's just some information about the valve itself. As you can see the sizes, and you can see the ranges of the patient annulus that we're able to treat, as well as the delivery system size, and again, the minimum vessel size. So these are some important things to keep in mind in terms of the valve dimensions, and I'm not going to go through this in detail, but just so that you can see between the ranges of 23 and 35, you look at the valve inflow, the valve outflow, and the important things are the anatomical considerations that we need to think about: sinus of valsalva width, sinus of valsalva height. You'll hear us talk a little bit about this when we're talking about our live case, but these are the important things to remember about the device. The other important thing to remember is the hemodynamics that are associated with this device. And you can see here, when we're talking about what kind of hemodynamics we get from an intra-annular self-expanding valve, you can see that if you move from 23 millimeter on the left to 35 millimeter on the right, you can see the baseline gradients going from 44 to 8.2 for the small valve. And when you get up into the larger valve, again, always within sort of a single-digit valve gradients at 30 days after the intervention. And you can as well look at the effective orifice area. And so you're seeing large EOAs for patients from one range of the valve size to the other, going from 1.6 in the smallest valve up to almost 2.5 in the large device. I'm going to skip a little bit through this in terms of, just basically reiterating single-digit mean gradients, even in those patients with small annulus. And that has been a focus lately when we're talking about female patients and smaller patients, that, gradients matter, hemodynamics matter. And in fact, if you look here in a comparison between Navitor and Evolut, you see similar, very low gradients with the Navitor system, which is intra-annular. As well, this translates into a low incidence of severe patient prosthesis mismatch at 30 days. And you're looking at 84% of patients with a valve less than 23 millimeters of the native annular diameter having insignificant patient prosthesis mismatch, obviously the same when we look at patients with a larger annular diameter. And obviously the large cells are important when we're thinking about lifetime management for patients and getting coronary access, and these large cells make it very feasible to do coronary access. We have a 22.6 French size, basically cell or hole to access the coronaries. So I'm going to skip over to this, and this is a great time to bring in my other two this evening. Techniques to optimize procedural outcomes. So we're going to have our panel, and we're going to talk about this. And so maybe I'll just get Santiago and Bassem just to introduce yourselves while we talk about, what are the techniques we need to use to optimize deployment when we're looking at Navitor.
Thanks, Anita. Thanks for having me join this webinar. My name is Santiago Garcia. I'm an interventional cardiologist based at the Crest Hospital in Cincinnati, Ohio.
Yeah, hi, thank you, Anita. My name is Bassem Shihab. I'm an interventional cardiologist at Ascension Via Christi in Wichita, Kansas.
Great. So we're going to talk a little bit about what are the optimal ways to implant a Navitor valve. And we're going to focus on cusp overlap technique and how to do this. So maybe I'll get you guys to talk me through, how do you use the cusp overlap technique, and describe a little bit for us, how you do this and why this is important.
Yeah, I think we learned quite a bit from other self-expanding platforms, the importance of this procedural technique. The goal here is to try to minimize pacemaker rates, and that has been closely related to our implantation depth. So the goal of these techniques is to isolate the non-coronary cusp, and the rationale for doing so is because that's where the membranous septum is, and that's where the conduction system emerges between the membranous and the muscular septum. So our attention then is focused on the implantation depth where it matters the most when it comes to conduction abnormalities. So I think we learned, usually this is achieving the REO caudal view. And we start typically a little bit higher. And this is a nice 6-step sequence. We typically align the inflow of the valve with the annular plane and make sure that the pigtail is at the bottom of the non-coronary cusp. And then as we start deploying, we expect, and I think you will see that very nicely in the live case, a little bit of movement, ventricular movement with deployment, which usually just a few millimeters, so that the final implantation depth tends to be around 2 or 3 millimeters, and that tends to minimize the risk of conduction abnormalities.
And so can you talk to us a little bit about the importance of pre-dilatation? And this is slightly different than some of the other platforms that we're used to using. But maybe we can talk a little bit about why this is important and, how should we be doing this for patients? So Bassem, what are your thoughts?
No, definitely. That's something unique for the Navitor system. It's definitely different than other self-expanding options right now we have, and should not be deployed the same. There's some similarity, but it's not exactly the same valve. So the thing with this nitinol is it has amazing and excellent radial strengths. It's just the opening force early on for the valve to deploy in a very uniform fashion. You need to have less resistance on that system. This way, you minimize any further resheaths of the valve. You have a single deployment, and you minimize any potential injury to any conduction system. And that's why pre-dilatation is very, very important, and actually required for the Navitor system. And early on, I was doing less aggressive pre-dilatation. I've been doing Navitor for at least 7-8 years right now with the earlier generation. And as time progressed, we started learning that we need more. We need to pre-dilate more. We need to pre-dilate more. And the way we do it right now is I use the mean diameter of the annulus based on the perimeter. And I either dilate the same number or I'll go -1, depending on how calcified that valve is. And what I've learned from that is the valve deploys much easier, much more controlled, single deployment, minimal resheaths, and there's almost no need for further post-dilatation. So that's why it's crucial with this kind of technology.
And I assume you're doing that with rapid pacing as well.
Yes, ma'am.
Yeah. So after the pre-dilatation, Santiago, you talked to us about that initial positioning and the initial deployment in the cusp overlap. And then, oftentimes we're going to go over into the LAO view to confirm. Talk to me a little bit about, the final deployment. And, we tend to deploy this very slowly, which is also perhaps different from some of the other platforms. And maybe, explain for the audience, why are we doing that? And what is the importance of this really slow deployment, even after 80%? Why is that important for the final deployment of the valve?
Yeah, so the sequence that is described here is what we tend to follow. So we start in the cusp overlap view. We deploy the valve there, usually unsheath the first part without rapid pacing, and then we start pacing. I wouldn't say rapid pacing, but usually about 120, 140. It's very controlled deployment. The patients are usually very stable. We just let the nitinol warm up and do what it does, essentially. So there is no need to really rush this deployment. Once we have contact with the non-coronary cusp, we typically go to the LAO view, and we make a conscious effort to sort of ignore the non at this point because we're very happy and pleased with the position, hopefully. And then at that point, we make sure that we continue to deploy the valve slowly. We centralize the catheter. We typically pull the wire inside the nose cone to make sure that everything is central. And then make sure that all the tabs are detached from the delivery system before we start removing it. And so it's a very controlled deployment. I think you're going to see an excellent demonstration in the next few minutes about how to do it. And there is really no need to rush it. Just let the nitinol warm up and expand fully before you start worrying about PBLs and other considerations.
Yeah, and I think that's a great segue to our case. So why don't we move on to our case? And Bassam, I'll let you describe a little bit about this patient.
No, I do agree with you. And just to add to what Santiago said, don't forget this valve is annular, so it's immediately active. So that's why you can really take your time, and you're going to see that on my case when we do the live case. The valve is immediately active. The fact it's an annular valve, and it gives me the luxury to take my time in deployment to really get it there for the first time without any problem. So this case is a 66-year-old female who really is young. So they created a predicament for us, referred to our social program for TAVI, mainly because of all the comorbidity she has from frailty and mobility issues. She has a lot of mobility issue from diabetic neuropathy, chronic back pain, hip issues, knee problem. So she is not someone we thought that cracking open the chest would be the best thing on her for long term from how much she's going to recover from that. But the fact that she's 66 created the first predicament on our lifetime management on this case. And if we're going to do TAVI on her, what would be the best option or the best platform from her? And then the second predicament was that her BMI was 42. So that added another kind of predicament on what would be the best option for this patient from gradient and also stress on the leaflet. As you see in here, she had, 3 out of 4 frailty system. Her STS was not that high, but really is not something that is guiding our management. We did her echo, she has severe AS, mean gradient of 45. And our team saw this lady and said, we think that would be the best option, but we have to decide on the valve. So we thought about balloon expanding, supraannular self-expanding, and we thought about the annular self-expanding. And we decided to go with the Navitor system on this patient because we believe that this valve will give us excellent gradient in an annular position with wide cell frame that will allow us to keep working on this patient in the future without impeding the coronary access, without impeding the next valve and valve option on her being annular. And that's the reason why I decided to go with the Navitor.
Yeah, that's an important point, I guess, before we show the case. So you can have great hemodynamics device, but you can't have both. And I think it took a little bit of time and convincing and doing cases to actually realize that the gradients have nothing to do with the location of the leaflets. Actually, it's much more complex than that. This is a good example of an intraannular device that has single-digit hemodynamics across the spectrum from 23 to the 35. And it's a little bit more complex than just the location of the leaflets. It's how the leaflets are attached to the frame, designed to open fully or not. And I think for those of you in the webinar thinking that there has to be the compromise, I will encourage you to try it. And I think you'll be pleasantly surprised with what this valve can do for you.
Yeah, I would tend to agree. I mean, we often used to think that, you know, the hemodynamics are related to position of the valve, and that's clearly not necessarily the case, as we can see. And for younger patients like this who have significant comorbidities, I think this is an excellent choice for your patient. So I'm excited to see what this case, how this case goes.
So we're gonna go next and see how the case is gonna play.
So from CT standpoint, we had fairly acceptable CT, slightly eccentric, LVOT, much less in the annulus. We got a perimeter of 68, which falls in the 25 millimeter Navitor right in the middle. Really, the area is like in the 350, 360, which is really good area and good perimeter. Next. The SOV is slightly challenging on this lady, slightly borderline. So all of them are like ranging around 27 by 27 millimeter, which still falls within the good characteristics for a 25 Navitor. The coronaries are borderline, with 11 millimeter for both the RCA and the left main. So again, with slightly shallower sinuses, that could be slightly problematic. Next. Some mild calcification seen on the hockey puck imaging. Next. We are very hardcore here on cusp overlap for self-expanding. So we usually deploy and we start with a true cusp overlap, and sometimes we do we go to the left side to compare that to our true near cusp and left cusp overlap. With the Navitor, I strongly recommend always pre-dilating no matter what. So my pre-dilatation technique when I talk about this is I just go by the minimum and I dilate. And the valve may not be calcified a lot, but there's a lot of scar and fibrotic tissue, and that can hinder the deployment and can have you do multiple resheathing and multiple deployment if you really don't have the valve expand well by itself. So I always pre-dilate no matter what, calcium or no calcium.
I agree with you. I think Jim Hermiller, what do you do?
And we have not had a lot of problem.
No calcified valve?
I'm with Bassem, but I just dilate every one of these, and I ran right into what he has. It looked fibrotic, and just despite the fibrotic nature and not much calcium, I had to redeploy. So just dilate it and then move on.
And you really do have to be careful when you look at your three Mencios, because it depends on how the three Mencios is setting up the Hounsfield units to how bad the calcium looks. I can take a valve and I can make it's like alias and an echo. I can make it look really good, and I can make it look really bad by just dialing up and down the Hounsfield units, like you dial up and down your alias on an echo. So if you do hemodynamics, you're going to see the gradient. If you have a gradient of 40 or 50, there's plenty of calcium there. And on this echo here,
and we're going to show the live gradient. Here we are. So that's 2 pigtail. And that's our baseline hemodynamics, guys.
Just breathe.
So I strongly recommend always to pre-dilate. And as you know, if you pre-dilate well, so let's go back to the presentation. But you're going to lose more minutes. You're going to lose more minutes than anything else if you don't pre-dilate. So perimembranous is going to be our challenging case in here right now. Next. So access should be fine. Really no significant tortuosity. Next. So this is slightly a challenge here. We have a very tight arch, so we may end up on the inner curve. So it's going to be slightly challenging trying to gauge the depth of the non-coronary and how much can be deep on the left. We may end up being deeper on the left just the way if we're hugging the inner curve. We're going to see once we put the wire in. The beauty of the Navitor and the FlexNav, the beauty of the FlexNav system, and these are the cases that I think it shines well, is that there is no rigid spine and that the FlexNav is just a cable. So really nothing pins the valve from self-centering itself. So, and I even sometimes pull the wire back, try to even give it more flexibility to allow it to self-center. So in these cases where I'm mainly on the inner curve, I just let the valve self-center itself, and that feature of the FlexNav is unique. And I hope we can highlight it on this case. I mean, it doesn't happen every time, but it happens most of the time. But that tight arch is always something I look at the Navitor at my arch and the angle and how that root is. Next. So really in summary, next is a 68-year-old patient. I'm sorry, a 66-year-old patient. Next, please. We're planning to do a 25-millimeter Vision Navitor. We have right access. We have 2 pictures already in. We're going to pre-dilate with the 18-millimeter. To pre-dilate, I'm sorry. We're going to go with the 18 true balloon right now.
And Jim, Basil's going to run the Envision trial for the low and intermediate risk, so it'll be a randomized trial against the commercial bed. So we'll get another answer for lower risk patients than the Portico trial.
Yep. It's going to be a very interesting trial with these hemodynamics and these properties of the Vision FlexNav. Take a breath. Ready? Okay. Start pacing.
180.
Stop. Stop. Start pacing. Okay, I have it. Perfect. Can you help me with the sheet spread? Quick pre-dill, really, it doesn't take that much time. And I think it actually saves time as time goes on. Thank you.
So
as you see, already some QRS changes.
Yeah, left
just
axis.
with pre-dilatation with an 18.
Yeah, some of
That's
the
the nature
pacemaker
of
related
the.
to the balloon, or sometimes even to the wire. Mervant, what is your experience? How much pacemaker you see overall in your lab, in your clinic?
There's a lot of criteria on what the pacemaker rate, but our pacemaker rate is single digit. You know, it can vary depending on what we're using, from 3% to 7%.
The LVOT, and when our balloon is deeper or the valve is deeper. But a lot of the times it recovers, especially after if the baseline EKG was okay.
The wire advance, hold it right there. The valve cross very easily, no issues at all, as you see right now. But it takes the tortuosity of the iliac so easy. Test.
So that is one of the nice features of this valve, that it gets very easily through tortuous aorta. It's probably the most flexible in the market right now.
Yeah, it's remarkable how it can, go up through tortuosity. I think
so. This is our two-cusp overlap. As you see, my valve is right at almost at the annulus plane. Not yet. There is no parallax really to take in here, which is good. So I'm really not going to adjust anything at this point. That's a pretty good view. You look at the lower ring, and the lower ring is really a straight line. So I'm going to start turning right now. Usually we start turning slightly faster until we get the ring to the actual valve level, and I let the valve go down.
And those markers are the most visible for all valves. Yep. You can see exactly.
And I just want to show you these rings. Look at these markers. I mean, they're pretty big. That lower part marker is 3. That upper part is 4.5. And that's the dynamic range we're talking about how this can be actually very helpful.
And the markers are 3 millimeters from the bottom, so you know exactly where the valve is being located.
Base at 120? Yeah, I agree. Keep turning.
It's a good example of a top-down deployment, too. You're barely touching the annulus with the stent frame.
Yep.
Jim, do you have to pace when you deploy it, or
you don't have to. I just think it's better. It helps.
We often pace
slowly
120
here.
to 140.
Here.
It's really, just makes you feel like you're in love. It's fine.
Yeah, I think it's helpful to...
Unless you have a bad RV. And if you have a bad RV, then I avoid it.
Yeah,
I think it's helpful to pace 120. It's
here.
just slow deployment. This valve functions immediately, so...
Keep going.
Be slow.
Well, one thing that I learned from Gus is to deploy
all the way,
slowly.
All the way,
to do one turn, go to have a cup of coffee, come back, have another turn.
Going. Stop pacing. Okay.
You see, the valve did not migrate during deployment. It was very stable.
And as you see, I pulled my wire back, inject. And these markers are pretty helpful. I mean, I'm definitely slightly deeper on the left, that's expected, but not as much as we have thought.
You're still in your overlap, so go over LAO and look at the left.
That's what I'm doing.
Yeah.
Exactly. I just wanted to show that first. Here we go.
What do you think of your rhythm?
Inject.
It's a little deeper on the left side, would
you
say?
You're 3 and 6. That's still very acceptable. So, and you're likely to maybe as you come over towards the greater curvature, come up a millimeter on that left side.
Exactly. I agree. So I'm going to take my 3-cusp view right now. Trying to align. See, as you see, these markers are easy to align. There's no guessing. I don't have to be on the X-ray all the time. Inject. I like it. I mean, I may end up going slightly deeper on the left, just how I am, but you know, it's not a bad thing. The rhythm, if you look at the EKG already, there is some slight changes. I'm gonna let it sit for a while and just see how this valve will look. But I replay the actual the last picture. I actually like my depths on the, I mean, on both sides. It doesn't look that bad. I would have been slightly shallower if I wanted to, but again, the problem with these, when you have a septal hypertrophy and not a very calcified valve, you don't want to be too much high because that can affect how the valve stability is and everything. So what I do in here is, if I like it, I just go beyond 80 a little bit. So I let that valve open up more. Still within range to recapture. I go 90%. And I observe her at this level for a little bit, make sure that that valve expands, sticks in place, give time for the nitinol to expand and do everything that it needs to do. Question, guys, meanwhile, as we wait for this a little bit, anything I can address?
Well, so Basma, I think that's a good point you made for those that don't do a lot of self-expanding valves, is that nitinol really will expand over the first few minutes. And some people, they like with it and they just want to let it go right away. If you sit around for 2 to 4 minutes and let it find its place, it'll be more stable for you. We've actually measured this when you first put it in and an hour later and it expands. So I agree with you. We typically will do a surface echo because it burns a few minutes here and gives us something to do. We look at a long axis, no color. That lets me see where it sits on the mitral hinge point and keeps my echo people busy and we're all happy.
Bassem, how deep is it in the cusp overlap on the non-conoid sinus?
I'll show you. I'm just trying to show the deployment one more time. I want to show you, like, as soon as I start opening, how my wire is back. I just try to take the wire as much as I can as I deploy to the nose cone. This way, it actually highlights more that flexibility of the valve. And I think if I had not done that, I would have been even deeper on the left. It would not have been that easy. So look at this here. I started forward and I tilted it. This way, I raised up the left with the wire being almost back. I'm going to show that again. As soon as it opened, my wire came back, and that's the beauty of that. And whether I'm using a TAVI wire or regular wire, I don't lose pacing. As you see, that curve is always touching, and you don't lose capture. If you're doing LV pacing even, it's not a problem at all. We've done it many times, and there's no issue. This is my, to answer the question, this is my true cusp overlap, two cusp overlap, my depths in it.
Is that fluoro now?
No, this is the one we saved.
Yeah, but if we do fluoro now, because in the 3-cusp view, it was 3-4 millimeters deep in the non-conoid sinus. So in the cusp overlap, if it was
Going back to the cusp, I will do it. Here we go. Let's go to the cusp overlap again.
Is the EKG still show the left bundle branch block, or it's been normalized now?
Can you show the EKG, please?
Yeah, it does.
It's there.
It does.
Yeah. It does have some loss, yes.
So I think you have room to go a little bit higher if you wanted. I'm not sure a big advantage from that, but if you wanted to recapture and redeploy, you could probably get it higher.
I usually don't.
I can.
You know,
I don't with the calcified.
The more recapturing you have, the more stroke you have. So look, I will accept it. I think that it's good enough.
Yeah, you're in perfect position, so you don't even need to think about capturing this one. And when you're in the cusp overlap, all you look at is the non-cornea and ignore the left. When you go rally, all you do is look at the left and ignore the other side. And you know, if you do your own three Mencios and you go from coplanar to, and you put an angle in there so that it marks where you are, and then go from coplanar to cusp overlap, you'll watch that angle and you'll see how it changes and how it folds.
We're gonna pace at 160 when we release.
Okay, that looked pretty good.
So I think it's time. We're gonna have to release if everyone agree on this. So I'm gonna make sure that my nose cone is back all the way in.
Approval.
Yep.
Looks good.
Okay. Start pacing at 160. And the trick here is a very, very, very slow release, guys. It's crucial to have a very slow release.
So you're pacing
And I'm just really
180.
You pace
160 right now.
180.
It's just not calcified. That's why. Usually I don't that much, but when there's not a lot of calcification, I do my best. The trick here is very slow release. Keep going. Very slow release. And make sure all the tabs are gone. And until it clicks. You can start pacing, Rob. Perfect. Let me bring. So here we go. All tabs are released. I'm gonna pull back and re-advance my wire. Here we go. I have it. Okay.
Excellent implant.
Pace at 70.
That's a great case. Maybe tell us a little bit, Bassem, about how that patient did. What was the follow-up?
No, I mean, that patient did great, actually. Never needed a pacemaker. By the next day, the left bundle has gone and had got much shorter. Gradient was in the single digit. Discharged next day. Saw her again multiple times. Very happy. Significant improvement in her quality of life and in her heart failure classification. I truly believe that was the best thing for her. I mean, there's something I want to say about the presentation is, as you recall, at that time, I was doing pre-dilatation with basically the minimal diameter. And since then, I became even more aggressive. And now I'm going by the mean diameter from perimeter, -1, depending how calcified it is, or the same number. And I found that even that helps me be more accurate in the deployment and do less resheathing on this, because it helps the valve expand and just land where I want to be. Also on the case, it's not in the video, but I've shown also how it's easy and how straightforward it is to engage the coronary on that case. I had videos on me engaging the left main and the RCA because of these white cells. It's just so easy and so straightforward. So, so really, I still believe that was the best thing for that patient at 66 years old, giving her single-digit gradient, and all the options in the future for coronary access or for future TAV and TAV.
Bassem, I want to call out a few things that I think you did during the case that I think are very important to avoid, resheathing multiple times. You actually started quite high. If you look at your vision markers, are almost halfway in the pigtail, and that to me speaks of experience, right? You anticipated what was going to happen. The device was going to move ventricular, and then as you have contact, annular contact, and you remove the wire. Can you talk a little bit about that? What are your goals and why you do it that way?
Yeah, and that's true. Dr. Garcia, I learned that the hard way. Before, I just used to go and try to center my markers where that valve is going to be. You try to open, it dives in the LVOT. You pull back, you lose your axis deployment on how you coaxial with the amp of the plane. So what I learned is my goal in here is to minimize any LVOT interaction. So once the valve dives down, which you expect to dive down a little bit, it doesn't move after that. So I start high up, and as I'm turning the system up and it dives down, once it gets to the position that I want from the marker, and these markers are very visible. I mean, there's no question, no guessing. I immediately just put my wire in place and just boom, valve stays in place. and I start my very slow deployment. So minimizing anything I can to affect any LVT contact. This way, in case I'm going to have a pacemaker need, I know I've done my best to minimize that from a technical standpoint. You know, at some point, pacemaker going to happen no matter what. I mean, this is the nature of self-expanding, especially when you have an underlying right bundle. But at least I know I've done my job, that I've done everything I can from a technical aspect to minimize that. And the idea is you want to touch the LVT one time and never touch it again.
Yeah,
So
I think it's an important...
Oh, sorry, go ahead.
Important comment. No, I just want to make one comment because I think there was a little bit of discussion about recapturing. And I think what you said is very important. You can have a final implantation depth that is perfect, but if you deploy the valve multiple times very deep in the LVOT, the damage may already have occurred. So I think it's important to get it right the first time.
So we just have a few questions in the chat, and so maybe we can address those. So there's some questions about, how does this valve perform in a horizontal aorta, for example? So Santiago, what are your thoughts about horizontal aorta and Navitor?
I'm not intimidated by horizontal aorta with this platform. It's very, very flexible. I think the comment that was made that is one of the most flexible systems in the market, I would agree with. Even though there is no flex function, I don't think it's needed. It will follow the anatomy, will track the wire very, very well. So our experience has been very, very good in horizontal aortas.
And so we also have a question about the cells. Now, you mentioned, Bassem, that you were able to very easily access the coronaries. We aren't able at the present time to do commissural alignment per se, but how important do you find that to be with the large cells? I mean, commissural alignment. Talk to us a little bit about that.
I mean, I believe commissural alignment is important for any platform for the future. Let's be very frank about that. In this platform, it is not as important as other platform. That's the difference on this one. Just because it's an annular valve, so it sits low from the tabs and everything in the system. And then the cells, even if you're slightly not well aligned, the cells are big enough to engage and do whatever you want to do. So even though I'm a believer in commissural alignment, but I think that platform gives me more leeway to do it in a way that is not perfect for now and still do the best thing for the patient.
Yeah, and there were some questions about, radial strength, and I think you addressed this already, but you talked about how the radial strength of the valve is actually good. It's just the opening force, which may be a little bit lower, and hence we'd like to pre-dilate our patients to make sure that, we can get that valve to open up well. And you showed a very nice example of pre-dilatation and how easily that valve opened and you were able to maintain position. One of the things I find is very different from the original system or the Portico is just how the valve doesn't move. And so we can place it exactly where we want to place it. And, we don't have this constant adjustment that we need to make to get the valve to stay in position. Have you guys found the same thing? Even in complex anatomy, I find that I can just park it where I want it to be and it doesn't really move.
Yeah, I would agree with that. And the other point that I would make, which I think is a differentiator, is usually the asymmetry between the non and the left is not as pronounced. So this is a good case where I think you had a perfect landing on the non, and I would say was close to being perfect on the left, perhaps 1 or 2 millimeters deeper, but we're not talking about 4 or 5 millimeters deeper on the left. So there tends to be more symmetry between the non and the left in terms of implantation there.
No, I agree with Santiago. I mean, the fact that this valve has no spine like the other self-expanding system makes it less rigid. So it's really less hugging the outer curve and allow the valve to almost centralize itself as it deploys. So that asymmetry between the non-coronary cusp and the left, like you said, it's there sometimes, but it's not as pronounced as the other system. And I really like that.
And so what would be some of your key takeaways, for our audience in terms of how do you choose a patient, for example, for Navitor? What kind of patients are you looking at? You're also the PI of the Envision trial, low and intermediate risk. So maybe talk to us a little bit about patient selection.
Definitely. So always very tricky. So far right now, the Navitor is only commercially approved for high-risk patients. So on most of my hardest patients, I try my best to do a Navitor system on them. Anytime that I have someone with a smaller annular size, 430 and less, I really go for hemodynamics. Anytime I have issues with sinus sizes, or with coronary height, I think about the Navitor system. Anytime I have some of the high BMI where I'm worried about gradient and ppm, I use the Navitor system. It's as time goes on, it's becoming more of our workhorse valve, way more than we had before. And hopefully the ambition right now, when we have more indication and low risk and moderate risk, will be very helpful for us. And the trial also is going to be talking about we're going to have a registry arm for bicuspid, and we're going to also have an arm for TAV and TAV and TAV and SAV. So technically, after this trial is done, hopefully the Navitor will be fully approved for all indication from any aortic valve stenosis at this point.
And Santiago, what are your thoughts on patient selection? What patient population are you using Navitor in now?
Yeah, I would agree with the comments. I think the small annuli is a good one. I would add that the borderline iliofemorals is another strength of this technology. The delivery system is very deliverable, and it can accommodate vessels 5.0. We have done very challenging cases, both in terms of size and tortuosity, and it delivers really well. So I would add that borderline anatomies, I think this is a technology to consider.
Yeah, and it's interesting. I did a case this morning, and it's exactly that. So it was a referral from another institution because of small vessel size, femoral access, just barely 5 millimeters. Very tortuous anatomy, elderly lady, high risk, but we got an amazing result, beautiful deployment, went into the femorals very easily, steered around, and removed with, no vascular complications, temporary left bundle that was gone a couple hours later. And some of that is the balloon, right? It's not even the valve, just ballooning it, but we got a beautiful result. So I think for those really challenging patients, it's an excellent choice as well. There's another question here in the chat. Are there any studies showing that higher gradients are associated with worse clinical outcomes in TAVR patients? I think we can talk a little bit about the SMART trial. We haven't seen the clinical outcomes, but, we consider, obviously, structural valve deterioration is something that everybody worries about, and hemodynamics, I think we all agree they matter. Patient prosthesis matters. Any other thoughts on patient selection?
Yeah, I think we could probably spend an hour just talking about that, but I would think that the direct answer is there is a fair amount of surgical literature on the issue, and yes, patient prosthesis mismatch is bad. There's data from the TVT registry showing that severe PPM is also associated with worse outcomes. There is data from valve-in-valve cases where if your residual gradients are about 20, that's a predictor of poor outcomes. So I do think that hemodynamics matter, and they matter probably most in patients who have a small annuli. And that has been the strength, that has been our argument of the interventional community when we quote unquote beat surgery, was that we don't have a sewing ring, that we can provide better hemodynamics. So I don't think we should deviate from that principle.
Yeah, this is a difficult topic. I do agree. That is, common sense says that lower gradient is better, but the problem is we don't have any data from a TAVR standpoint that says that it correlates to better clinical outcome. But for me, the way I analyze this is, if I'm going to compromise lower gradient by having a supraannular design and affect my lifetime management on younger patients, I'll be hesitant just to go based on gradient. But if I can have the best of two worlds, and this is what the Navitor has, is you can give me an annular design that give me the best gradient and the best lifetime management, I'll use that until we have more data on the clinical outcome about how that affects our patient outcome.
Yeah, and I do think it's important when we're choosing a valve for our patients that, it's patient-centered valve selection. So what does the patient need and what's going to give us the optimal result? We talk about lifetime management in the future, but lifetime management starts with the first valve. The first valve we put in, getting the best result we can, and then moving forward from there, I think.
The Ambition trial, Bastian, will follow up these patients for up to 10 years, correct? So we will have answers on this question, whether hemodynamics matter or not. I think it will take time. It won't be something that we see in the first few years.
I agree with you, but that's the beauty of this right now is like, you're giving the patient the best gradient without compromising lifetime management with a Navitor. And that's the beauty of that valve until we have this data. I mean, I'm willing to wait at that time as long as I know I'm giving them the best of both worlds.
So any other takeaways for our audience from the live case? Any other messages, we can share to talk about? We've talked about patient selection. We've talked about the procedure. Any other thoughts that you guys had on this platform?
Maybe I would ask a question to both of you. If you are someone who may be thinking about bringing a third valve to your lab, if you want to comment your experience in terms of learning curve, how many cases did it take for both of you to feel comfortable? And what would be your, I guess, 2 or 3 take-home messages for a new user?
Yeah, so I came from a program where we had all 3 platforms, and it's a great question. I think when you're considering adding a third platform, some of the things you need to think about, what is your overall volume, but then is there a patient need, is there a patient population? And I think we've talked about the fact that, definitely that's the case. I think if you have self-expanding experience, the actual learning curve was pretty steep. Like, after 5 cases, you feel very comfortable. And I think that's a reflection of, the fact that the valve is quite easy to deploy, the fact that most of us are quite comfortable with cusp overlap. And even if you're not, I don't think it takes an inordinate amount of time to get comfortable, to Mike Reardon's comment during your live case, knowing what you're focusing on in the cusp overlap view, going over to the LAO view. Pre-dilatation was something that we weren't doing. So I think just getting used to that and choosing, what balloon to use and how to do that. But it's not a huge lift, pre-dilatation. It's just getting used to that workflow. I don't know, Bassem, what are your thoughts?
No, I mean, definitely exactly what you said. I mean, I started using this in 2017. So, I don't even remember my learning experience, but I train a lot of our operator in the lab who does Navitor right now with me. And, the main thing that helped them bypass the learning curve, which was fast, by the way, is I told them this is not like another self-expanding system. This is its own class. You have to deploy it differently than what you used from self-expanding. Use the thing that you know, but there's a lot of differences. Pre-dilatation is extremely crucial on this one. You should not bypass aggressive pre-dilatation. It helps the case a lot. And then the third thing to improve the learning curve is learn how to do it slow. Take your time in deployment. This valve is active very early on. It's an annular system. So don't rush the deployment. And as long as you are really looking at these 3 parts, that learning curve is usually like 5 and less cases, around 5. And it's just, the rest is the same like any other TAVR.
So there's some comments in the chat about conduction system disease and deciding on a pacemaker, et cetera. Maybe you guys want to speak to that. What are your standard monitoring practices post-TAVI with Navitor? What has your experience been? I think, Bassem, you mentioned you're in single-digit pacemakers. Maybe you guys could talk a little bit about, how do you monitor these patients? What's your experience been?
Yeah, I think our practice has been really determined by the baseline EKG and the baseline conduction abnormalities. If the patients come to the lab with the right bundle or left anterior fascicular block or first-degree AV block, we typically will put a pacemaker from the neck and we'll leave it in for 24 hours at least, irrespective of the valve that we put in. Most of those patients actually have, well, not most, but I think it's a fair number of them actually will have no issues during deployment of the valve, and we just watch them and remove the pacemaker the next day. If there is any abnormality, we probably watch them for 48 hours. And if they don't need a pacemaker, we send them home with an MCOT, with the monitoring device for a couple of weeks. We tend to have a relatively high threshold to consult electrophysiology because they typically assume that we want a pacemaker. So unless we feel strongly that the patient needs a pacemaker, we like to wait 48 hours before we make that call. The other patients that don't have conduction abnormalities, we typically remove the wire at the end of the procedure, and we just watch them like any other TAVR. Most of them go home the next day.
Mm-hmm. Yeah, almost similar as Santiago. The only thing different is like I don't do same day discharge with any self-expanding system. I send them home the next day, unless I see changes in the EKG. I send them home with an MCOT. Other than this, I think being careful on the implant technique and patient selection. I look a lot at the LVOT size, how much it tapers. I look a lot at calcification there. I look a lot at the perimembranous septum lengths to guide what platform I'm using on my patient if I can. And I do believe that experience and the more you do, you're going to drop your pacemaker number. And data have shown that, as you start early on with any new platform, you're going to see higher pacemaker rate. And as you do more, that numbers drops and drop to the single digit. And that's what we have seen in our program with me and the other operator of the program also.
Talk to me a little bit about your antiplatelet strategy after Navitor. What are you doing? Are you doing antiplatelet therapy for patients? What's your current practice?
I'm using single platelet agent on most of my valve right now. Just give them Plavix and move on.
The same. Single antiplatelet therapy, unless they have a coronary stent, a recent coronary stent, or if they come to us on an anticoagulation, we just keep them on the same anticoagulation regimen after the TAVI.
Yeah, we're aspirin only at my institution. We just give aspirin if they're not on aspirin, and we don't add a second antiplatelet.
Yep.
And if you are adding an antiplatelet therapy, how long do you keep it on for? What's your duration of antiplatelet therapy in general?
So in general, it's the only reason why we do that. It would be coronary stenting, and that will be determined by the complexity of the PCI, but not by the TAVI itself. So if it's a recent stent, probably would be 3 months, unless it's in a left main location or something that we have concerns about, which may be longer, or it's acute coronary syndrome. Will be 1 year.
So we didn't talk about post-dilatation. There's a couple questions in the chat about this. If you have to do post-dilatation, first of all, I guess, how often are you doing it? And if you do have to do it, how do you perform it? Do you want to take that one, Santiago?
Yeah. Actually, I can tell you that with some data. We're going to be talking a little bit at New York Valves about the collective commercial experience with Navitor, and we presented some of that last year. We have now updated numbers, but it's a single digits. Post-dilatation is performed less than 10% of the cases. And I think that speaks for what we discussed today. There has been an emphasis on pre-dilatation, making sure that you do it right the first time ahead of the valve deployment. The motivation to post-dilate usually is driven by the usual factors, residual gradients, PVL, or incomplete stent expansion. And the strategy has been typically determined by CT sizing. And so we don't want to exceed the annular size with our balloon choice. I personally have done it very infrequently. It has typically the cases where I've done it, I have seen also some foreshortening of the stent. So you typically can get the device to be a little bit higher when you post-dilate. So a case like the one that Basen did, where was perfect deployment and there was not much calcium, I think you probably will be taking some risk in post-dilatation where you go from perfect to perhaps a more aortic position, and I wouldn't recommend that. So I've been very selective in the use of post-dilatation, and in part because I've been very pleased with the PVL results. So it's the skirt, which we haven't discussed a lot about, but the skirt has this unique morphology that really works well, and that has been a significant improvement from the first iteration of this device.
Yeah, I agree. I mean, I'm very careful about post-dilatation, but mainly it's because once you appropriately pre-dilate, you almost don't need to post-dilate. But if I think I need to post-dilate either from PVL or some expansion issue, it's usually not a gradient problem. It's usually one of the two. Then I'm always careful. Like in that case that I did, I would definitely not post-dilate unless I really have to, because I agree with Santiago. But really, if you prep the valve properly early on with pre-dilatation, odds are it's going to be less than single digit, like very, very low number for post-dilatation. And I go by the mean diameter also.
Yeah, and I think we've seen the same thing. We post-dilated valves, we didn't pre-dilate. And now that we're pre-dilating, we don't seem to have to post-dilate. Your case that you showed had, calcium, but a lot of fibrotic disease of the aortic valve, which is more common in women, incidentally. But, there's a question here, is there an amount of calcium that we require to anchor this valve? I mean, I think you showed that's not necessarily the case, but do you want to speak a little bit to that? When you're looking at a CT scan, evaluating the calcium in the leaflets, is there a point where you think you need a certain amount of calcium?
No, I mean, that's a great question. Definitely I would love to have more calcium on any case. It makes my day easier. But no, definitely, as the case shown, I really don't look at calcium. Calcium will not tell me if I'm going to use the device or not. Calcium will tell me how to do my technique. How low should I implant? How should I pre-dilate? Should I post-dilate or not? So I look at the calcium and the CAT scan just to guide me on how I'm going to do my procedure and the technical part of it. Then actually really should I do a Navitor or not? Calcium does not affect the Navitor.
Santiago, any other thoughts about that?
Yeah, I think I would say that I've been guilty of initially not pre-dilating based on calcium, and I made that mistake. And then as you said, you pay the price at the end when you have to post-dilate more than you would like. So I agree that I just pre-dilate all the valves now, and I deploy them as usual, irrespective of the calcium score being low. Like in this case, I mean, there was some conversation about avoiding that step, but I think it's important to do it systematically. And then on the upper end of the calcium score, I think the number itself does not intimidate me, but if it's a nasty bicuspid valve, I always get concerned about TAVI as the right choice, in particular in a young patient that may have a surgical option.
And so there's a couple questions here, and maybe Bassem, you can start with this one since you've had such a long experience with the platform. Any issues with halt? Hyperattenuated leaflet thickening, what's been your experience?
No, I mean, my experience is that early on when we had the halt issue with the original portico, when we were doing this CAT scan, we didn't understand. And we later realized years ago that there was no problem at all. It was just an overcautious kind of thing. I have not seen halt, and our program do 30-day CT routinely on all our TAVR.
Really?
We do 30-day CT on them, and I can tell you that platform that we have may have the lowest halt on all other platforms that I'm using from what we're seeing so far in our program.
Santiago, have you had any experience with halt with this generation of the device?
No, but we don't do routine CTs, and I think unless you look for it, it's very few patients with halt will have elevated gradient. So I can't really speak to it. In my previous job in Minneapolis, we used to do 30-day CTs on all the commercial TAVRs, and we will see a fair amount of halt with commercial valves. But obviously, Navitor was not commercially available back then, so we don't have a lot of data in that data set from this platform. But I suspect we will see it as is the case in every single device. The question is how often will it happen and whether it will translate into clinical situation that requires treatment.
Yeah, and I think that's a great point. I mean, we're not looking for halt either in all patients, and we can actually see it in surgical valves if you're looking for it. The question becomes, what do we do with it if we see it? If we triggered to do it because we see an elevated gradient, I think that's different. Then you have a reason perhaps to do some sort of treatment. But we don't do routine surveillance. I'm not sure what I would do if I saw it if the gradients were normal. So it looks like we've pretty much wrapped up on all the questions. We've got less than a minute left. Maybe I'll just ask each of you to give you some parting words for the audience in terms of, your most important takeaways for Navitor. So Bassem, we'll start with you.
No, I mean, this has been a great session. Thank you, Anita, for leading this. Thank you, Santiago. I can tell you, if you don't have a Navitor on your platform as one of your valve, you should. It's been an amazing journey for me, and and even so far, I'm having amazing result with my patient. I can tell you there's a lot of newer innovation coming in, even on the Navitor platform that Abbott is doing. So the future is bright and with a lot of newer improvement. I mean, don't say no until you try it. That's what I'm going to say.
Yeah, so we only have a couple seconds left, so I think I will end with that. I think if you're looking for another valve to try, I would definitely give this one a go. The learning curve is short, the hemodynamics are great, and it's definitely worth trying in your patient population. So thanks everyone for your time this evening and for joining us in this first webinar on TAVI with Navitor.
Thank you.
Thank you.